Good evening and welcome. My name's Luan Ismail. I'm the convener of the network, and it's great to see so many of you here, and particularly since we've had a bit of a break for a couple of months, but we're back and delighted you've chosen to be with us this evening. Epilepsy imposes a great burden on individuals, families and the wider community. The Epilepsy Foundation of Australia notes that 4% of Australians will have epilepsy at some stage of their life, and 1 in 200 children live with epilepsy. The disease may impact an individual's educational opportunities, their independence, their psychological health, and it does increase the risk of premature death. This evening's presenter, Professor Mark Cook, one of Australia's leading epileptologists, is pursuing what is perhaps the holy grail of epilepsy research, being able to accurately forecast the occurrence of a seizure. The critical ingredient in addressing this challenge is data, and we're talking very large volumes of data, which Professor Cook's team has used in their research. Additionally, Professor Cook and his team have also developed an implantable device that continuously monitors the electrical activity of the brain. To tell you about this exciting development, please welcome Professor Mark Cook as he comes to the lectern to deliver his presentation. Mark.
Thanks, Luan, and thank you all for coming. I was hoping not to put everyone off with the title of the talk being a seizure detection device rather than a seizure prediction one, because everyone thinks of seizure prediction, but I hope to show you how that all sort of joins up. So first of all, epilepsy is really common, so it's a very serious problem worldwide. At least 1% of the population have epilepsy chronically, and many of the people who have epilepsy aren't controlled with medications currently. And for a long time I thought, and certainly early in my career, about where's Simon Wheel? About the time I started working with Simon in '93, we had a lot of MR technology, and I imagined that we'd find a cause for seizures on people's MRI as a regular thing, and we'd cut it out surgically and we'd fix their seizures, but it turned out not to be so straightforward. We often couldn't find the cause, and when we could, it was unresectable or in a location too difficult to access or just too big. So the upshot of it was that we still can only provide surgical therapies, potentially curative therapies, to few patients, and most patients are still reliant on regular anticonvulsant medication. So it's a lot of people. But we've got a lot of drugs. So here's about where I started in the epilepsy world, when there was only relatively few drugs, and they were easy to handle, and you can see this enormous explosion in drugs that's occurred in my working life. Now, you might have imagined that this would cause a lot of people now to be fixed by our marvellous new medications, but unfortunately that's not true either. The same proportion of people, 30 or 40%, are still not controlled by medication, even with this proliferation of drugs. Though we do have much better range of side effects to share amongst patients. And that's the other downside of it. All of our drugs have bad side effects. These drugs all work on your brain, and your brain doesn't like them very much. So we do have a lot of room to manoeuvre with the medications now and find a better spectrum of side effects for patients generally, but it's still suboptimal. So there's a big problem. The other problem is that we have to give patients drugs all of the time, because seizures have long been regarded as random and unpredictable. And so you give medications all of the time to protect them from what might be a pretty infrequent event. Infrequent but disabling. Now, I presume that a lot of the audience here tonight weren't going to know a lot about epilepsy. So epilepsy, most people are familiar with through major convulsions. So they know about people having what we call tonic-clonic convulsions. An old phrase for them used to be grand mal convulsions, where they would collapse to the ground and shake and bite their tongue and lose control of their bladder. And they're a very important type of seizure and very dangerous. But most people with epilepsy aren't having seizures like that. Only about 15% of people with epilepsy have tonic-clonic seizures as a significant feature of their epilepsy. Most are having minor seizures. And the minor seizures, for the most part, in adults are caused by a structural pathology of some sort involving one part of the brain. And that part of the brain has a short circuit which produces symptoms related to the area of the brain that it starts in, but then often progresses to loss of contact. And during that period, people often have unusual movements. They often chew and swallow, and they might behave in a confused manner. It's not always apparent to people with them though that they're having a seizure. And these events last 30 to 120 seconds typically, after which they're a little confused. And this period of confusion is very important because during that period of confusion they can forget everything that's happened in the moments before. I'll just show you a couple of YouTube. So this is a typical focal seizure.
You all right?
37,000. A few years, I'm going to have to sell my entire collection. Might as well start now. This is cool. Where did you get it? I bought the rifle from a friend I knew in Wyoming, and he said, you're going to see something like this once in your life. It's .4 hunting buffalo. It's a 44 Nike caliber. This was the most powerful caliber made in 1874.
Yeah, it was powerful enough to bullet that 800 yards away, you could still bring in a buffalo.
Yeah.
Buffalo.
So you get the picture, but that shows a lot of the features of seizures. There's loss of contact, she's not responding to people with her. There's these peculiar mouth movements, which are not always present, but can be very prominent as they were here. These strange repetitive movement of the hands, which can appear quite complex or quite purposeless. And this will go on for, as in this instance, a couple of minutes, after which people are confused. These are just off YouTube, obviously, because there's heaps of stuff like this on YouTube. With good examples like this. This guy's asking his brother after a seizure.
Yeah. Well, I'm filming you. You did have a turn. Yeah, you did. What were you reading on the laptop? What were you reading about, that news story you were telling me about? You were just reading it and telling me about it.
So that shows the important part. He's asked immediately after the seizure that his brother's witnessed about the seizure, and he has no recollection of it. So very important, very common, very typical. And his brother's got some hilarious videos up there. Hilarious to us watching them now, not hilarious to the patient, you know, where his brother says, oh, you know, you dropped all the stuff in the toilet and the toothbrush and thing, how do you think it got there? And the guy's completely befuddled by how all this has happened. So the machinery that's involved in memory is part of the same machinery that's involved in the seizures. So your memory is often flushed by the seizure activity, you have no recollection of it. And that's very important, as we'll see. So why are they a problem? So often when I give these talks, you know, or when you speak to people from Centrelink or employment agencies and you describe to people that patients have seizures that cause them to go blank for a minute or two and then they're a bit confused, they say, well, how's that a big deal? How can that possibly interfere with your life? Why shouldn't you be able to get employment or engage in other activities because of that? And it's true enough that the seizures are pretty infrequent. In this study I'll show you later, what it was at Dean, 0.05% of time was spent in seizure activity in patients who were chronically recorded. But it's a bit like having a Ferrari that might suddenly stop working unpredictably for 0.05% of the time. It looks nice in the shed, but you can't take it out on the freeway. So it's a big problem, and the unpredictability of them is the big issue. And obviously things become dangerous. Swimming's dangerous, having a bath is dangerous. Driving certainly dangerous potentially, and there are significant restrictions around that which tend to limit people's life quite a lot when they have a diagnosis of epilepsy. They might injure themselves seriously and they may not be able to work. As well, the seizures are often humiliating. People are ashamed of their seizures, and there's terrible stigma attached to seizures too, which makes this even worse. This is a quote from Roman times, this one. Those who after the seizure remember neither the fall nor the affliction, so a good line and gives you a good indication, and some who remember and are ashamed, and that's very true also. And a good name the Romans had it for it, the disease of the assembly, because if it happened at the assembly would have to be cancelled because it was a bad omen and of course a great humiliation for the sufferer. And for a long time, epilepsy was thought of like that, and still is in many cultures, an infectious disease. This was a very widespread idea, and before everyone laughs about that, I still meet patients who tell me that their neighbours don't let their kids play with theirs because they might catch it. So that idea is still widespread, that and or it's a psychiatric disease. Most patients feel like this though. Losing jobs, the pills, can't drive, you know, there's a lot of downsides to it, right? And it's not only that, it's that people often fall and injure themselves, and this is one of only a relatively minor event that can happen after a seizure. So I've got people paraplegic, tetraplegic, and of course dead after seizures through injuries to their spinal cords and falling in dangerous places, baths and showers. And of course there's this, so every week I deal with this sort of thing where people have seizures driving. Sometimes they don't know they've got epilepsy and this sort of thing happens. So these catastrophic events which are dangerous not only to them but to everyone else. And if you put seizures, car accidents into YouTube, you'll find millions of hits and millions of news reports, so it's a serious problem. As well, there's this risk of death, as Luan mentioned, so 1 per 1,000 per year probably die suddenly and unexpectedly who have epilepsy. More significant risk for those who have frequent generalised tonic-clonic seizures, but it can happen to anyone. So it's quite a serious and important cause of death for young people. Now that's my dad, and that's my daughter. Now my daughter's a chef, or training to be, but my dad was a chef too. And unfortunately, when he got to the peak of his career, he developed epilepsy. And so doing things like that are obviously dangerous. So he couldn't work anymore. So it's a big problem, and it affects people's lives and their day-to-day stuff enormously. And as well, they're often unaware of them. And because they're unaware of them, they can't keep track easily of their seizures. And that's a big problem. These are the sort of diaries that people bring along to me. There's two separate diaries there. This one's not too bad actually, because at least it's arranged in some sort of logical fashion. Most of the time they're just freehand, or people bring along scraps of paper with their diary entries. I like this one because this lady's stuck a little bit, that's a little sticky label that she's put on the calendar there, and that scrawl, those lines, and when she's realised that she's had a seizure, because she's realised looking back at this piece of paper later that there are all these peculiar pencil marks on it that she's made during that phase of the seizure where she has the repetitive hand movements, and she's able to recognise sometimes retrospectively that she's had seizures because she finds things like that around the house, or broken glasses and things like that. But this is the quality of the information that you get. So could counting seizures help? Well, obviously people are often unaware of their seizures. They keep these diaries, but it's hard to know how accurate they are, and people wax and wane with keeping the diary. But if they don't keep a good diary and you don't know how often seizures occur, it's very difficult to manage seizures, because your management, so people come and see me every day for their epilepsy, and I try and figure out how bad their epilepsy is and give them tablets and adjust their tablets according to how frequent their seizures are. But that's very hard if people don't know actually how many seizures they're having. They might think they know, but it turns out they don't. We had a great video EEG example a little while ago that we did through SEIR that I'll tell you a bit about later on, where the patient and her mother's with her all the time, described that they'd had no seizures during the week of monitoring, but in fact she'd had 154. And remarkably, her mother was with her during a lot of those events. They were fairly subtle, but they're obvious enough. So it just shows that even when you've got a good witness, you might not know. As well though, all new drugs are tested against diaries. So if you get into a drug trial at our hospital, we give you a diary, you come back with your diary, and we figure out whether the drug's working. And all the regulatory agencies use this as their gold standard for whether the drug works or not. Probably we've wasted lots of very good drugs, and on the other hand, we've probably validated lots of drugs that perhaps didn't work as well as we thought. So if you could count them, you could do lots of things. You could improve the accuracy of your treatment. You could improve safety if you could count them accurately, because you could actually tell perhaps whether patients really were having seizures, because patients say they're not having seizures, there's no witnesses that they're having seizures, so they're allowed to drive a car, they have a crash, or they have an accident at work. So if you could do it accurately, you could improve their safety. And as well, if you could count them accurately, you might be able to forecast them in ways that hopefully I can demonstrate to you. So how can we count seizures better? So there's been a lot of interest in wearables. So wearable technologies obviously have really captured the popular imagination, because everyone's familiar with Fitbits and how your activity daily can be tracked. And using things other than an EEG, the EEG is an electrical recording of the brain activity on which we normally rely, it would be very attractive. So you can use an EMG, so you can put an EMG which records muscle activity on the biceps or other muscles and measure the jerking movements that occur with seizures. Obviously that's only going to catch seizures that have jerking movements, and as I mentioned, that's a minority of seizures. electrodermal activity changes in the sympathetic activity to the skin produce changes in its electrical conductivity, and this can be measured, and that might be helpful, although as well that seems helpful mainly for major seizures. ECGs might be useful because people's heart rate changes with seizures, and that can be measured. And similarly, you could use accelerometry to see how they're moving. There's lots of other techniques, I'll show you some of these soon, mattress sensors and so on, and video systems to try and capture the seizure activity. And the basic idea with all of these is that you could capture this activity and somehow relay information to assistants, so that little kids with seizures might wear a device that alerts their parents or carer to the fact they're having a seizure. And this would be useful because kids' life is restricted a lot if they have seizures, because their parents naturally worry about them all the time. They become socially quite restricted often, and they don't integrate normally with their peers as a result of overprotection and the hazards involved with the seizures. So, you know, that would have huge benefits, and to adults as well. You could capture seizure activity in some way, transmit it to the cloud, notify carers, emergency services. You could do lots of things, but it depends very much, or given acute therapy, but it depends very much on capturing the events. Maybe these different techniques are useful for different types of seizures. So generalised tonic-clonic seizures you might catch with accelerometry. With ECG you might capture focal seizures, because even though there's not a lot of motor activity, the heart changes can still occur with them. This electrodermal activity also has been shown to sometimes be abnormal in focal seizures, and certainly generalised. And so these specific types of detection might suit particular kinds of seizures. How do you use it though? Do you use it continuously, or do you use it just overnight? There are problems with wearability and the stability of the systems and their recording, whether they're overnight or daytime. And most of these systems so far are used chiefly overnight, because obviously monitoring people personally is tricky overnight. That's one of these systems. So this is an EMG system worn over the biceps, and you can see that device has got a couple of electrodes on the back which listen to the muscle continuously and wirelessly transmit EMG data and capture major seizure activity. But personally, I don't think anyone's going to be wearing them around all of the time. You know, these aren't things which are terribly wearable. They could get a lot smaller and more practical, but they're still only going to be good for generalised tonic-clonic seizures, I think. And they can capture this sort of EMG activity which can be modelled, and it's possible to detect the features of the seizure that you're interested in. So that side of it seems to work well. The electrodermal activity, similarly, you can measure these changes. Studies have shown most patients with generalised tonic-clonic seizures have these significant increases in electrodermal activity, less commonly with focal seizures. Significant degree of latency. There's a lot of speculation that detecting these sort of changes might ultimately help preventing sudden unexpected death in epilepsy, though I don't think that's a claim made with any real certainty at the moment. That's one of these devices that's available commercially at the moment, the Embrace system. And there again showing that the electrodermal activity changes during the course of the seizure. You can see the seizure occurring here in this EEG, and the changes in the electrodermal activity shown here throughout the course of the event and after the event. And it's thought by some this period after the seizure, where EEG activity is suppressed, is particularly important potentially in the cause of sudden unexpected death. The ECG is very attractive because you can record ECG easily. It's got great signal noise, and there are good systems for extracting it easily and automatically analysing it, so that would potentially be very useful. And so that probably doesn't project that well, but the heart rate down the bottom here, you can see changes before the seizure. You can see electrically the seizure happening here, but changes in the ECG occur before the seizure and during it. So there's a range of abnormalities that occur in EEGs around seizure activity. And one company that make devices to stimulate the vagal nerve, so these vagal nerve stimulators are implanted in the chest and connected to a nerve in the neck to stimulate to prevent seizures, now have modifications to them that allow them to trigger according to variation in heart rate. So that's been an interesting development. More recently, the same company have also placed in their device accelerometry hardware, so they can capture cardiac variability and as well accelerometry and tell whether people have fallen over or there have been other changes in their status. And the accelerometry is widely available. I mean, we all have it in our watches and phones and things now, and these devices usually are placed on the limb and are meant to detect the movement. And I think it's possible that we learn lots of interesting things from these devices. Mal Horn's been working with these sorts of systems in Parkinson's disease like this for a long time, and shown that you can measure therapy, whether people are being under or over treated with these systems, and also that you gain many unexpected insights from the system. With this, for instance, it's possible to see whether people are developing complications of the medications they're using unexpectedly by how frequently they press the button on the device. So there's other things you can learn from the systems, and it's possible that we do get lots of additional information from these sorts of wearable devices with accelerometry. But the main obstacle is distinguishing from normal movements, and toothbrushing, you can imagine, and many other activities complicate the use of these devices in a practical sense, and wearing them overnight. So there's lots of issues like that. Certainly they have been shown to have a reasonable sensitivity, but quite high false positive detection rates, often about 1 per 24 hours, which is quite a lot if you're relying on it to notify people for emergency care. Video detection systems are interesting. There's lots of data in video streams. These systems have been used mainly overnight, though there have been some trials of patients done during the day. And these systems can potentially develop a lot of subtle activity with seizures, but to date the results haven't been that encouraging, with still fairly high false detection rates, and obviously using them continuously throughout the day is tricky, but overnight might be practical. Here's one such system from the Dutch group looking at a prospective study capturing this activity. Quite significant latencies from the start of seizures that you can see in the grey zone here, from when they're detecting it in the orange area here. Near-infrared spectroscopy is an interesting technology that measures changes in blood flow to the brain through the skull, so these aren't invasive systems, and people have reported changes using these detector-based systems where there are changes in the blood oxygenation, which increases slightly before a seizure, then drops and then increases again. And that's shown here. There are 2 seizures marked by the arrows in this recording, and they're showing these very small bumps in the signal. But I don't think that's going to be terribly valuable practically. This is a wearable near-infrared system, and I don't think this is going to be very successful. It's hard to see how this could be developed and miniaturised to the extent that it'll be a practical management tool. This is a patient of mine with a seizure dog. So these dogs, seizure alert dogs, so these dogs are very popular. A lot of people go out and buy these dogs. These dogs cost about $10,000 in Australia. More if you want to get this training done into a more sophisticated level. People in the device world often ask me whether patients would be prepared to pay the sort of amount that would be necessary for a lot of the devices that are becoming available. And I say, well, they pay $10,000 for a dog, so I guess they would. There's a lot of argument about whether these dogs are actually detecting seizures or not. Certainly some can. I have had patients who've had dogs which do accurately detect their seizures. Generally they've not bought the dog specifically for that purpose, but the dog's been able to do it, so that's interesting. They're rarely able to replicate it though when the dog dies. So potentially there are lots of advantages to wearing wearables and using other non-EEG methods of seizure monitoring, but it's very limited by the fact that most of these systems aren't very good at detecting the most common type of seizures, the focal seizures with impaired awareness that I showed you earlier. But they're reasonably good at detecting the generalised tonic-clonic convulsions and might be useful in overnight events. But there's very little real-world data, and I'm yet to be convinced about their usability in the long term. So other ways of counting better? Well, we could use an implantable system, and we did that with a first-in-human device a few years ago, where we implanted these systems into the head, and this was with the intention of predicting seizures. So the objective was to record data so that seizures could be accurately predicted. And you can see in this person's skull we've made a large hole. We've put these electrodes in, so you can see these electrodes which are applied directly to the surface of the brain, and all this is connected by a wire that runs down the neck to a unit here which sits underneath the collarbone like a heart pacemaker, and records and wirelessly transmitted the data to a handheld unit that the patient carried with them that displayed a series of lights indicating the risk of seizures in the hours ahead. And this worked well, so we were able to get good data from these systems. We got nice EEG from people. This had never been done. People had never had EEGs recorded continuously over long periods of time. We only ever did it over a week or 10 days when people were in hospital with a large grid on the surface of their brain while we were assessing them for surgical treatment. So it had never been done with patients walking around engaging in their usual day-to-day activities over long periods like this. So we were able to see actually what was happening. And I won't go through this table other than to say it was possible to predict seizures. We couldn't do it accurately for all of the patients in this study, but it was possible to predict seizures. And that was very exciting because to date that had only ever been speculated on. And we're able to give them good warning time. So it's a small study with 15 patients in it, not all of whom we were able to collect data from for one reason or another. But this shows the average seizure warning times, and it averaged about 90 minutes. So these were very useful warning times. People can do a lot in 90 minutes, but they can make themselves safe and potentially take some acute therapy for their seizures. So there's a lot you can do if you can predict seizures. This is the sort of information that the patient would get. So these are the lights that would show up. These lines each represent a 24-hour period where the patient would see a light on the top of their handheld unit. A blue light would indicate 0 risk of seizures, a white light a moderate risk, and a red light a high risk of seizures. And the little lightning bolts are when seizures actually happened. And you can see the seizures are all accurately predicted there. But there are also red blocks where seizures don't happen, and that's to be expected because there is a lot of EEG seizure activity which isn't accompanied by clinical events, and that's just something we have to deal with. But it was very accurate. You can see this is the best performer in the study and a very useful device if it works well for someone. We learnt lots of other stuff though doing this study. We learnt that the EEG is not stable when you put electrodes on the surface of the brain. But more importantly for our purposes tonight, we learned that patients were just awful counting their seizures. And we knew that they were pretty bad, but we thought that they were out by probably 50 to 100%. And we knew that because when we have them in hospital monitoring them, we know they're pretty bad at counting their seizures. And this graph is showing you the number of seizures the patient's reporting versus the number they're actually having on the y-axis there. And you can see there's patients reporting 0 seizures but having over 200 seizures, which marries pretty well with the story I told you before about the SEER patient. That's the same data being shown in a different way. So you can see for the individual patient there, the black bars represent what they're reporting and the red dots what they're actually having. And we knew what they were actually having pretty well because the handheld unit had an audio recorder in it that was triggered by detected events, not predicted events. So whenever an event was detected electrically, we could listen and hear what was happening. And we could hear often if people were having a seizure or if other people were assisting them and so on. So it was in fact quite easy to tell. We probably still underestimated slightly, but amazingly, with that small additional stream of information, you could dramatically change what you understood about the seizures. And we learned all of these other unexpected features of seizures, that the seizures had specific populations, that they had particular intervals between them and clustered in specific ways, and that all of these features were very unique and individual to each of the patients in the study and very, very, very different. We also learned that these populations that we discovered related very closely to the patients in whom we could predict seizures best. So there were lots of other aspects to the information that we recorded that let us understand better how to predict seizures in future. But most importantly, we saw that there were these very important relationships between seizures and time of day. So on these graphs, which represent the individual patients, you can see on the y-axis the day of the study. So you can see there going up to 680 days of the study, and on the x-axis is the time of day with the grey bar representing night time. And the different colours represent whether the seizures were clinically manifest or not. And you can see through the clustering of the colours there that the seizures tended to occur at particular times, and remarkably, seizures that were clinically manifest only occurred at certain times of the day for many of the patients. And this wasn't a feature they'd typically recognised, or often it was something that they'd recognised, but we never heard that information as they were telling it to us. And I guess that's something you come across a lot in clinical medicine, that there's a discovery, and in retrospect you identify an event that the patient's been describing to you for a very long time. So that and other longer cycles in people's seizures are very important. And these cycles have been known about for a long time. So this is a book from the mid-1700s describing these cycles, and the ancients related them to phases of the moon and the sun and so on. So these were thought to be very important controls in epilepsy seizures, and a lot of people still think that. And early the last century, people did detailed work on patients in epileptic colonies where they could be very closely monitored continuously by the large numbers of staff and their seizures tracked. And they also recorded similar patterns of seizure activity to what we'd seen, but this information had been lost in the intervening decades. But it was possible to show that if you had this information about these rhythms in epilepsy, both the circadian rhythms and other rhythms, both shorter and longer than a day, you can improve seizure prediction enormously. So you could take this sort of information about when the seizures were actually happening, relate it to the time of day, and create a probability measure of when a seizure was likely to occur during the time of day, and create a seizure prediction system. So on the top here shows a prediction system with the red bars indicating seizures. The black dots are, let's say, the EEG activity, and the asterisks are when we predict a seizure occurring. And this is using something similar to our original system, just on the unfiltered data, showing lots of false positives. But by including the circadian data, as Pippa's done here in this study that she published a couple of years back, you could dramatically improve with a very simple measure your ability to predict seizures. And unlike our other seizure prediction system, this didn't rely necessarily on analysing all the features of the EEG signal. You could rely very heavily on just understanding the pattern of the events. So if you could count the seizures accurately and you knew exactly what time they were happening, you could actually do some very good work with seizure prediction. And that's a graph showing how much that could improve prediction over some of our original techniques. So in the orange there for the individual patients, or some of the individual patients in our implantable device study, you can see that the circadian data in green actually outperformed the original data analysis techniques just through circadian data use alone. And then if you combine both techniques, you can get some very powerful prediction happening. We did some work with IBM as well to look at other ways of improving this prediction and using deep learning strategies on their neural chip to see if we could improve seizure prediction, which we applied to the patients in whom we hadn't early been able to develop successful algorithms, and showed that it was possible. So there are other ways of analysing the data as well, which are very important. But having collected the seizure data and counting it accurately, we could relate it to a lot of other things. So it was possible to look at seizures and temperature and see that there's a relationship for patients between seizure and temperature. The spikes that people have on their EEG between seizures also seem to relate to temperature, not in a consistent way, but in a way to a particular individual that might be incorporated in a seizure prediction system. The absolute humidity seemed to be important, strangely enough, in seizures. Now, there's big caveats on this, because the temperatures people are exposed to during the day at work and at home don't necessarily relate that closely to the temperature and humidity outside. But nevertheless, there are these very striking patterns in the seizure frequency according to various environmental factors, which we don't really know. But our ability now to measure these things gives us a lot of dramatic insights and novel insights into how the whole system's running. This is some more work from Pip looking at how you can explore some of the longer cycles in seizure activity. So a very common thought had been that the moon related to seizure activity, and in more recent times the idea that hormonal cycles, so in women that seizures relate to their period, has become an accepted fact, and that we understand that the hormonal changes might trigger seizures. But we could see, looking at the patients, that there were cycles within a day. There were cycles across days, where some days were more likely to have seizures occur, and also some weeks of the month where seizures were more likely to occur. And this is true for men and women. Perhaps I'll just skip over that one. Again, this is some work that we've published recently looking at this, showing that not only is that true for our small study of patients with Neurovista, but for a very large study looking at over 1,100 patients from a seizure tracking device where people log their own seizures. We could take a subset of those patients for whom we thought this was reliable, and we could see that for each of the individual patients listed on the y-axis there, we could look at how strong these cycles were, and the density of those dark lines rising vertically show you that there's some strong cycles less than 24 hours, very strong one at 24 hours, a pretty strong one out at a week. And for individual patients, all these black marks represent other cycles which are going out to 3 months there that are still relevant for them. But you can see just how different this is for every person. But there are some very strong constant cycles, but a lot of variation in these other long cycles beyond that, and also a lot of shorter cycles. So we were able to answer the question as to whether it's true that there are catamenial seizures. So catamenial refers to occurring with the menses. And we could see that cycles over 3 weeks, certainly those at around 28 days, are as common for men as for women. So that's quite important. So all this is great. Everything I've shown you, with the exception of that last bit that was created with the seizure tracker system, has been done with the data that we acquired from an implanted system. But the problem with the implanted system is exactly that it needs to be implanted. We need to make a big hole in people's skull and put it in. And although patients were very interested to get that done, in fact, which is a testimony to the disability that they suffer as a result of their seizures, unfortunately it wasn't possible to get people to invest in this, and so the company collapsed and we were left with the data that we had. But a less invasive device would be very helpful, and as you can see, it's perhaps not necessary to collect the very high resolution EEG data directly off the surface of the brain that we had been doing originally, but perhaps we could make do with data of lesser resolution collected from a system under the scalp. Now we can't put it on the scalp, because if you put the EEG electrodes on the scalp, as we do for routine work, the signal's degraded by movement and activity, sweat, and you just can't keep electrodes on people's scalp for very long periods. We can keep them on for up to a week now, but that's not enough to catch these cycles. These people are having seizures separated by days, weeks, months sometimes. So we need something better than that. But we could put it under the skin, where it would be free of the artefacts of movement, sweat, and the other things that contaminate our normal recording. So some time ago I met Graham Clark. So this happened about 2002. I was introduced to Graham, and Graham showed me this piece of hardware, which was a cochlear device. And at the time we'd been interested not only in detecting seizures and predicting them, but we were interested to directly stimulate brain to try and prevent seizures. And obviously this was going to be very dependent on detecting the events occurring, but we thought these devices could do it. So we set to work and started a project with Cochlear. So that was the first foray with Cochlear, where we engaged with them about developing these devices, and Cochlear were initially very interested in this. But a problem with the share price of implantable devices for hearing purposes meant that Cochlear pulled out of this, so we were floating loose for many years. But we still kept working with the technology, and we were interested to work with the technology Cochlear had, because it was the right size and they had a good way of powering the system, and a good way of taking data off it that we could use for exactly our purposes. And you can see with this Cochlear system the hearing component of it, which we wouldn't need, but we would need this connection here, which provides power to the system and also takes data off it, which is magnetically connected across the scalp. So we would need a system like this, but we could implant them like this, and we had an idea of a bionic system like this, which had electrodes going over the skull, under the scalp, and we had a variety of configurations of electrodes imagined that we could use, and that was our first prototype system there, which we used to try and encourage people to invest in us, unsuccessfully for a very long time. In retrospect, no great surprise, going around with a Tupperware box with that sort of stuff in it. Looked pretty exciting to me at the time, but didn't excite anyone else. But we got more sophisticated, and the team, Yuri and Chris Allen and others, created these systems where we did have workable systems, and we worked not exactly like this. This was one of the sorts of systems that we had imagined, with electrodes that might be drilled into the exterior table of the skull. That would still require a bit of surgery and was complicated for other reasons, but it wasn't terribly invasive. So we worked on systems like this, and we experimented a lot with sheep. So we put, there's sheep skulls with a variety of electrodes put in. So we put these systems in sheep, and we had them out at pasture for 12, 18 months transmitting from these systems, and we could see that it was possible over these periods with these type of devices to record good quality EEG for the necessary periods. And We also did a lot of testing. Sorry, that doesn't show up very well there. These are studies on the skull of the animals, making sure our electrodes were compatible with them, showing that we weren't causing any great trouble with either of our varieties of electrodes that we were using. And as well, and most importantly, the surgical techniques available to put these systems in quickly were available, and that we could do them very quickly. And this is important because to make these sort of systems commercially viable, it depends very much on whether you can get the devices inserted and the patient sorted out very quickly, as prolonged hospital stays magnify the costs and reduce the profitability quite considerably. And other people had obviously been working on similar things. So UNEEG are a Danish group who, about the same time as we were, unbeknown to us initially, working on similar systems, modifying a hearing system to implant under the scalp. They have a different approach to this than us and a different type of system, but it's looking at a similar thing. Medtronics have a cardiac monitoring system called Link, which they were interested to modify for recording EEG. So this records ECG from the chest normally. It's put under the skin of the chest to record ECG to sort out cardiac problems and can be left in for a couple of years. And so obviously this was very attractive, but it doesn't record continuously data. It only loops data and captures events for about 15 minutes in total. So there's restrictions around this device that we've been doing some work with Medtronics on recently to see if it's viable. But they're showing in this illustration here how the device can pick up the sort of spike activity from the hippocampus in a sheep that they're recording there from comparable implanted electrodes. So it looks quite attractive. But this was very encouraging news for us, so we knew these devices were feasible and could collect the sort of information necessary. A big break came a couple of years back when we competed in a Shark Tank competition in Miami and won, which was terrific because until then we didn't actually have any money, but this gave us enough money to pay for Al, who was working pretty much full time on the job at that time. So this was a huge breakthrough for us. And later we created more sophisticated devices, so this is some of the work from our patent around it. It's in fact changed a little bit since then, but that's not terribly important. You can see the basic idea is a cochlear unit with a long electrode with multiple contact points, and we have a system for deploying this under the scalp in a single manoeuvre so that the device can be put in a very short stay procedure for patients. At the moment with this sort of system, they'd still have to wear an external unit, so it would sit like that, and as with a bionic ear device, there'd be an induction coil parked over the system and running down to a wearable which would go into their pocket or on their shirt. So this is the current state of play, and we've been working on that for a while, and in June this year Cochlear finally came on board, largely through the good agency of some carefully placed pieces of reporting by our good friend at the Herald Sun, Bridget O'Connell, who did some great work for us promoting this story at a time when we were going to be seeing Cochlear and I think getting them across the line. So at the moment then we have the company Epiminder manufacturing this device at the moment, and we'll perform some clinical trials next year to establish the viability of the system before moving to a large multi-centre international study, hopefully in the year following. So we've come a long way. Cochlear are a significant owner of the company, as well as the Bionics Institute, St Vincent's Hospital and the University of Melbourne. Along the way we discovered that one problem with these systems is they generate vast amounts of data, and something we hadn't given a lot of thought to was how we would actually analyse all of this data. With the original study that we did, we had 15 patients and at the end of it about 70 terabytes of data, and so figuring out how to actually handle all of that's an enormous problem. And you can imagine if you've got implanted devices like this, streaming data continuously analysing is tricky. So Dean's led the way in establishing SEER, our company which manages this data, and we manage it for scalp EEG data as well as down the track the implantable systems, and this has been incredibly successful. Ultimately, as you saw with the early slide with the wearable, we envisage a very similar system where devices like this will be streaming data continuously. They'll be combined with other devices, either on board the system or with wearables that will tell you not only if patients are having seizures, but if they're having a long seizure, if they've fallen over, if they've stopped moving, if they've got a cardiac irregularity with it, where they are and how to get to them. It might even be able to administer treatment down the track, because the treatments might not necessarily be medications. So there's all sorts of possibilities. But most importantly, systems like this will give people independence back, and it will let them get about their normal activities, because when we can detect seizures accurately, we can start to predict seizures accurately. And if we can predict seizures accurately, we can improve people's safety, quality of life, we can tune their medications, we can change everything for them, we can give them their independence back. And that's the bit that's really important. So I hope I've convinced you that the chronic monitoring is feasible. And we've certainly got lots of new insights into epilepsy from a small study, and now expanding it through other work with seizure and other implantable systems that we've been involved in. We understood a lot more from this about clinical aspects of epilepsy that we didn't know before, or that we thought we knew. We can see that it permits prediction, that we can see there's a structure and a pattern to epileptic activity. It's not random. It's possible to understand this, but it requires huge amounts of data and the ability to manipulate and analyse that data adequately. Remarkably, these features are highly individual, so everyone is genuinely different. So these all have to be custom built to the individual. With it though, we'll have the opportunity to improve management and safety, reduce stigma, because I think ultimately if we can see, or if everyone can see that this is an electrical condition, it's a condition which can be understood and treated in that way, we'll take a lot of the stigma away, a lot of the idea that it's infectious or psychiatric or in some other way damaging to others. And we'll open new therapeutic opportunities. So a lot of people involved, no doubt some people will come up to me afterwards and tell me I've forgotten them on the list here. I've tried to include everyone. There's a lot of people involved obviously, and you know, both from the university, at the Bionics Institute, St Vincent's. We've had lots of collaborations with Medtronics, the original NeuroVista team who made the implantable system, colleagues at the University of Pennsylvania and the NIH have all been involved in this study, and many others. But special thanks to a few. And there's Pip living it up recently in Venice on yet another one of her overseas jaunts. And Pip obviously has done an enormous amount of this work with her PhD. There's the A team. David Graydon, I can see hiding up the back. I did threaten to have a more embarrassing photograph of him, but I threw away the Christmas party one with the moustache and beard. Dean there in another hairstyle incarnation. Chris Williams from Bionics, and of course Alan, who's been with us all the way through, but I don't think Alan's here tonight. And our reliable skull that's featured in so many of the press shots. Wendell, who I don't think is here tonight either, but Wendell's another neurologist who's also been helping with the project over the time. And I had to put this picture in because Michael's very wary of photographs, but that's the surgeon involved, and Peter Seligman also, and Rodney, who's here tonight, I don't think he has any photographs in existence, but Rodney's been another critical component of the team. Rob Klupax on the right there with Graham and myself, has, before he took on his current role with the Bionics Institute, been handling this project for us, and it's really been terrific having his assistance. So thank you all for your attention.
This evening marks the 10th anniversary that the network was established 10 years ago this evening. So in that time, with the very generous support of sponsors, with the generosity of speakers like Mark, and with the support of the community, we've managed to deliver 100 odd events. And more importantly, I think, I hope that we've been true to our mission to share with the public some of the exciting developments that are happening in the biomedical sciences. So I want to thank our past and present sponsors, and thank the many presenters who have given their time generously to come and share their science with us. And I hope you've found any event that you've attended worthwhile. So I want to thank our current sponsors. They make they've made this event possible. Thank you very much. Thank you for your company this evening. Please join me in thanking Mark again, and we look forward to seeing you at a future event. Thank you and good evening.